So Nunkri Nungi, Richie Paul Worley, Nabi Puteri Maori, Pomerangkong, Narajiri Rui. G'day, Paul Worley is my name. I'm the Executive Director for Clinical Innovation here in the Riverland Academy of Clinical Excellence in beautiful Murray Bridge, which is Narajiri country, where education has been ongoing for 60,000 years, and it's great to be able to continue that tradition of learning from people around the world and from people close by, so that we can improve the health services that we're providing to our communities. Today we're very privileged to be able to learn from one of the new roles that have evolved in our local health network, and that is having advanced studies in academic practice as part of training to be a rural generalist. People would know that the Riverland Academy has a medical pathway supporting the career development of early career medical officers to become rural generalists, and as part of that they need to undertake advanced studies to get some specialist skills, and that can be in academic practice. And today we've got the opportunity to hear from the path maker in our region for that. It's Dr. Alwash, who's an ACRRRM Registrar and also undertaking his AST in academic practice in partnership with Adelaide University. And it's great to have them join us today. So over to you, Al.
Thank you very much for your introduction, Professor Worley, Paul, and thank you for having me on the grand rounds this afternoon. Thanks to all of you attending live, and for all of you watching the recording, I hope you find it as useful. So indeed, we're going to be talking about academic practice, the first time the AST has been done here in the Health Network at RMCLHN. So let's get on to it. The first thing we need to do before we talk about advanced specialized training is, as Paul said, it fits within a wider context, particularly here of the training to become a FACRRM or a fellow of the Australian College of Remote and Rural Medicine. So the AST is part of a broader scheme of training that also includes these other bits that we call core generalist training. So you'll see junior doctors, PGY 2, 3, 4, 5, and so on, in all of these other aspects when they are ACRRRM registrars, primary care, secondary care. You'll see them in the ED, you'll see them in primary practice. They'll be undertaking their education primarily through the college itself, as well as through some accredited courses. And as with any fellowship, we have exams to complete. So that forms assessment, that can be logbook, that can be the notorious stamps, the MCQ, the case-based discussions, and so on. And the advanced specialized training is part of that. It's a compulsory aspect, which I'm going to talk about in more details, but there's lots of options. So these are the 12 options that we have within ACRRRM when someone wants to or needs to complete their advanced specialized training. Okay, I've highlighted academic practice in black. That's what we'll be talking about today. The ones in green are other ASTs that we have approved within our health network. So we're very lucky to have those. You'll have recognized, for example, Dr. Overwill in emergency medicine. You'll have seen Kyle, Dr. Selger in population health at the fracture clinic. And looking forward, I've had confirmation this morning that at Riverland General Hospital we're going to have, hopefully, Aboriginal and Torres Strait Islander health coming up, adult internal medicine, anesthesia, and pediatrics. So if we can get all of those things going, that would really be the majority of the ASTs that ACRRRM has to offer. And I think that's a fantastic thing for the network. And we'll go into more detail about that. So these are all the options that someone can choose to undertake an AST. What are the requirements in general for an AST? It comprises 12 months of training. I say mostly because if you do the surgical AST, that's 2 years. And as you saw before, that's from a total of 4 years of full-time training. if you were to conduct a 1.0 FTE, it should take you at a minimum of 4 years if there's no recognition of prior learning. The nature of assessment that we saw there, it really varies depending on which advanced specialized training you do. It may include exams, such as another stamps, which is like a Viva, for example, for ED. It may include some kind of report or manuscript. I think population health, academic practice includes that nature of assessment. Or for anesthetics, for example, it's generally a third-party certification, like a diploma in anesthesia. And each site, in order to host a registrar doing that, requires assessment and approval by ACRRRM itself to say, yeah, we're happy for the health network and this site to be able to provide that training. Specifically, we're talking about academic practice today. This is what I've been doing. The requirements which I want to talk about today in some detail are that you need to be PGY 2 or above, so you can't be doing it in your intern year, and you have to have completed 12 months of core generalist training, which are all of the things that I pointed to on one of the first slides, or the ED or the primary care or whatever else it may be. Complete that 12 months of core generalist training. Within the 12 months, they do academic practice. We're doing 4 hours per week of education activities, and you should maintain a log of the same, whatever you've done. And it's expected 0.5 FTE of the registrar's time will remain in clinical work. That's not specified. You could work in the ED, you could work in primary practice. It just has to be some kind of clinical work. So it's not a full-time role in teaching and research, which we'll talk about some more. You may choose to work towards an academic qualification, such as a master's degree, but that's not mandated, which does make it easy and more streamlined and more affordable for lots of registrars to take part in the academic practice AST. One of the biggest pieces of assessment specifically for this, which is what I'm currently undertaking, is a project. It's a piece of accessible written work, approximately 4,000 to 5,000 words of length, which I'm sure a lot of you will be used to, at or near master's level. That can be a piece of research where you're contributing to current knowledge in a particular discipline. That's essentially what clinical research is. You're adding data to what we already have. Or it can involve developing a practical resource or a tool. So either of those is acceptable, and you produce a report on it. For the supervision itself, you need a clinical supervisor. So for example, if you do time in the emergency department, or if you do time in primary care, you'll have someone who's overseeing that aspect. In addition to having an academic supervisor who will hold an academic tertiary qualification and may hold a medical qualification. So why have I gone into it in such detail? And you can see the quotation marks and that nature of things. When we talk about rural areas, rural health networks, it's important to appreciate that we have exactly the same facilities that's afforded to those who are living in metro places. So if we can find a way to meet the requirements in a pragmatic sense with lower resources, where you may not have all of exactly the same staff that you would like to, then it's important to know what is the minimum requirement. What do you need to hit in order to be good training? So we're very lucky here. We have Professor Worley, we've got Dr. Mendham, but in those other areas, it doesn't have to be a doctor. It just needs to be someone who's at a high level in the academic sense and holds an academic tertiary qualification. So now that I've told you what academic practice is all about and the fact that I'm doing it, why do we need it? Why is it useful? Why should we continue to have it at RMCLHN? I think the most useful, in my view, and you're welcome to disagree, the most useful aspect is you're really attracting doctors, senior doctors, registrars, those who will become ACRRRM fellows, who are interested in and have an increased ability to educate the next generation of registrars, to take part in that medical education process, okay? And that's not only within the postgraduate space, so for interns, PGY2 teaching and so on, but now, for example, that we're having the Rural Medical School in Renmark by Flinders University, That, for example, is going to have an increasing need for education, someone to provide tutorials, someone perhaps to provide lectures. And the more that we can provide in terms of doctors who can fulfill that need, the more we attract other professionals to the area, the more interesting it becomes for them. The higher quality training they receive, the more likely they are to stay. Okay, and that has a developing effect, a crescendo effect. It gets better and better. When we do these research projects and you have clinicians who are taking part, who have academic roles, that increases collaboration with those tertiary education providers. We talked about the University of Adelaide, but also Flinders University and SA, for example. And this is applicable throughout Australia. And then, the obvious last piece of the puzzle, you develop clinicians who have skills and experience carrying out research in rural areas. So we've spoken about equity, and in one of the conferences I attended earlier last year, that we don't have as much access to research in rural and remote areas. If we have people doing academic practice ASTs who are able to do research, who are carrying out that type of research, that increases our availability. We have more people on the ground, we have more clinicians providing oversight, and that's a real benefit. Okay, so let's talk a bit about my experience, and you can see what I've done, how it's worked for me specifically within RMCLHN across Berry and Renmark. So I'm PGY 7. I'd already completed my core generalist training time prior to commencing, as was the requirement. I managed to complete my exams within the AST year as well, so that wasn't as applicable. I managed to do it in the same time, which is one of the benefits. You get that flexibility. And after this, I'll be doing my dedicated anesthetics time. So within the ACRRRM training pathway, I've done my AST relatively later in the course of training, which is probably fairly typical. It's usually one of the last things people will do. My clinical supervisor, so that's typically across ED and other things that I do, but I'll talk about that, has been primarily Hamish, Dr. Esk. My academic supervisor is primarily Professor Worley and also Dr. Amy Mendham. I'm very appreciative of them both signing up to do that. It's the first one. The research project that I'm doing is a phase 2A clinical trial, and if we have time, I can talk to you more about that. In terms of the education component, just to clarify briefly here, the 0.58 FTE has to be dedicated to clinical work, and the remaining 0.5 FTE should be divided between teaching and research. So within the research, I've been doing the clinical trial, and within teaching, I've been doing to some of the medical interns who are here watching this today. I've done a session for allied health students. I was teaching the medical students in the first year at Renmark. So that's a wide variety of different types of teaching in tutorials and simulations, small groups. And a typical week for me might look something like this. This is more recently, the latter half of the year. 2 days, Monday and Tuesday at Renmark Nursing Home, where we're doing the MCT trial that we can talk about. That's primarily a fairly normal hours type of job. So that would be, 9 to 5 or similar. The Wednesday has been allocated to me for teaching and medical education. That's typically involved the intern teaching at approximately 1 o'clock most days. This also includes time for the preparation of teaching materials, getting simulation work done. So it's not only about the deliverables, but it also takes time to prepare those things, to think about what you're doing. What are the goals of what you're teaching? How are you going to deliver it? That all takes time. Thursdays for myself have been doing orthopedic surgical assist or the rural generalist ward round followed by an ED shift, one of the two. And Fridays generally rural generalist ward rounds plus or minus an ED shift, depending on how many hours I've done that week. So you can see it's mostly office hours. The Thursdays and Fridays can both be pretty long at 12 hours. But the other benefit that you can see is that by default, when you do this AST, you have a variety in the work you're doing. You have to do some kind of clinical work that's typically separate, at least 0.5 FTE. You have to do some teaching, and you have to do some kind of research or development of a project or a resource. So your week is naturally split at least among 3 different things. which I think helps to keep people from being bored. It helps to provide that stimulus to be excited about going to work. So that's one of the benefits. Now, how are we tracking for time, Paul? I think we're pretty good. 1:16. Yeah.
Yep, you're going well.
Beautiful. So I've got about 5 minutes. I'm going to give you a quick overview of what the research project is that I've been doing, and this is at Renmark Aged Care Facility. As I say, it's a phase 2A clinical trial on medium chain triglycerides in aged care residents. So let's talk about it. Medium chain triglycerides are a type of fat, specifically a triglyceride, that are a chain length of 6 to 12 carbons, okay? Anything smaller is a short chain triglycerides and vice versa. These types of fats are found naturally within foods, as you can see below. For our trial, we selected an MCT oil that was purely derived from coconut, okay? So the only ingredient is modified coconut oil. It's modified in the sense that it's refined down to only the C8 carbon length medium chain triglycerides. This is the processing, physiologically, the digestion of medium chain triglycerides as opposed to longer chain triglycerides, and the time to ATP, which is much shorter, and the ability to be broken down into ketone bodies primarily, which is what we're interested in. Ketones are an alternative fuel source for cerebral function. So why is that important? In those with mild cognitive dysfunction, such as those who are developing Alzheimer's dementia, it's theorized that one of the ways that they have reduced cognitive function is the reduced ability to process glucose to provide energy for brain function. Ketones bypass that insulin-dependent glucose mechanism, okay? So it's an alternative fuel source of the brain. It has shown in previous larger studies, the phase 1 studies, that some of them have shown a mild improvement in general cognitive function. What we haven't seen is a recommendation or enough data surrounding the safe and tolerable dosages, an established dose range. How much do we give to patients that's safe and effective? So that's what we aim to do. We're looking at the intersection between dose and symptoms as we titrate up the amount of oil that participants get relative to their own body weight, so it's participant specific, and then we have a look at them on the same dose for a period of time. We use that data to make recommendations on a safe and effective dose range that we can use for larger studies or that we can establish directly as, for example, a new standard of care. This is how we've done. This is the type of time frame that we're working with. We've divided it into clusters. It's a step-wise cluster trial. The titration period there you can see written as dose is over 10 weeks, and then all the participants are on a stable dose period where they have the same dose for the duration of the trial, and then we check things at the end. We stop the titration if they reach if they have any issues, so they no longer tolerate a higher dose. If the study dose max is reached, which you'll see on the next table, i.e. they reach the end of the titration, or they have significant ketone levels measured between 0.5 and less than 3, a nutritional ketosis. This is what it looks like week by week. We increase in very small increments. We're talking 0.05 grams per kilo each week increment, and we recheck their markers, which I'll show you on the next slide. But a typical dose at the end of our titration of the study is about 33 ml in the whole day, divided in 2 doses, just to give you an idea. These are the markers. These are the things that we're looking at, and they're looked at different intervals depending on the necessity for safety and how useful it is to measure that thing every week or every once in a while. So stool chart, behavior chart, and other potential symptoms, they are related to safety and tolerability. They are measured weekly. We then, at other time intervals, will check things like the cognitive function, their appetite, and their physical activity, as well as doing some serum blood tests, the liver function test and lipid profile. That's at baseline before we start the study, at the end of the titration of the dosages, and then at the end of the stable dose period, right at the end of the study. And then we can see, as a secondary aim, if there has been any measurable change in cognitive function or any of those markers. That would be a good thing to see if we can, but it's not the primary aim. Progress so far. We're on week 15 of 22. We've completed all the midpoint assessments. The mean daily dose that I just alluded to was 33.2 mil. And the tolerable dose, the dose that's reached on average is 0.41 grams per kilo, which is a very good finding, considering that the maximum titration of the dose is 0.5 as per the study protocol. So what this means is most participants tolerated the product well, almost until the max dosage. There were no withdrawals primarily due to side effects, and were scheduled to complete the study approximately at the end of January. I think it's the week of the 26th. And that will be the first time that we really get any sense of, as a secondary aim, any change in cognitive function. But it may be that we need an even longer period of time to see changes of that nature. Beautiful. Thank you so much for allowing me to present today, and I welcome any questions.
Thank you, Al, for that presentation and explaining. A couple of comments. We actually did have a mental health AST accredited in our region. It still is there, but hasn't been taken up recently, interestingly. Yep. I also want to acknowledge the work in the research side of things of the team of Emily Matthews and Asini and Lee, who have really supported you in that. I noticed that you talked about variety. Yes. Variety can be a two-edged sword, can't it? It's very stimulating, and at times you can have many masters. How are you finding that as a registrar? It's a very different sort of registrar role from just being, say, a registrar on an orthopaedic ward, and all you do is follow what that orthopaedic team does day in, day out. How are you finding having the different parts of your job?
Yes, that's a great question, and it depends on the level perhaps that the registrar is working at and the nature of supervision within the different jobs they have. So for example, within the research study, it's very much collaborative, as you say, with Emily Matthews and yourselves and everyone else. And I am not the most senior person in that role by a long shot. So I'm the one that's learning. I'm picking up the skills. I'm contributing, but it's certainly more collaborative. Within the other aspects of what I currently do, I would say it's a fair bit more independent. So within the ED role, I'm primarily independent within the emergency department. And for example, on the RG ward round, I'm currently filling, something that will be similar to a senior role. So as you say, you have many masters, but in that aspect, you are conveying what you're doing to other people, but really they're working with you more as a peer. The surgical assist is great. It's certainly probably a lower cognitive load. Again, you're assisting as a peer, you're working with the orthopedic surgeons, and the responsibilities kind of end at the time that you close up the skin. So it really varies depending on what you're doing. I think if you were fully in a place where you had many different necessary supervisors and you needed extensive supervision, I think perhaps that would be more difficult or more taxing.
Yeah. Lucy, you have a question. Thanks for joining us from University of Adelaide.
Thank you, and thanks, Al. That was a fantastic presentation, and I'm really interested in your research. But my question today really is about the academic AST, and I'm interested in what you plan to do with it. Like, what is this a space filler for you, or have you got grand plans for your future?
I think I see my role in the first instance stretching to capabilities for teaching, depending on what clinical role I fulfill, which is not entirely clear as yet. But I would like to host or have probably primarily medical students or interns and have a supervisory role in doing that. Perhaps involvement in rural medical school teaching or involvement in tutorials for medical students. I think my use of the AST will be within those lines, within the teaching side of the academia, for me personally.
And research?
Research, I think I would be open to it in different natures of roles. So, for example, there's areas where you may instead be a principal investigator relating to your clinical work, where there's a different type of work that you're doing. It's not so much on the groundwork within a nursing home, but it may be that you are providing a clinical service and that's being studied, and you're contributing data to that side of things and helping with the write-up and the analysis and so on. And I think having the skills from this AST will allow me to say yes to more of those opportunities.
So for the audience, I'm just thinking, you know, clinicians have a role within a research team to kind of be both the people that provide access to data, as you've described now, but also to be on a steering group to kind of have the, is this useful? Does it pass the pub test? And how would we put it into translate it into clinical practice? And so you're not necessarily the doer, but you're the commentator and the access provider. Yeah. Okay, cool.
I think that's very valuable. Yeah.
Yeah, thanks, Lucy. I think there's a question from one of our interns in the simulation centre.
Yeah, hey, can you hear me?
Yes, certainly can.
Yeah, it's just Will here, Al. I was just asking about the trial. Was there a slide on the primary endpoints? Or it sounds like you said, did you say it was cognitive function? Was that the primary endpoint? Or were you doing lean muscle mass as well?
No. So these are good questions, Will. Those types, that nature of outcome is a secondary aim. The main thing that we're looking at is the dose tolerability and safety data.
Okay. Yeah.
So the main thing we're looking at is, you know, what dose do we get to? What's a safe dose? At which dose do we encounter side effects? At which dose are we in ketosis? The secondary markers, like you were referring to, primarily what we're measuring is changes in physical activity through a questionnaire, changes in appetite through a questionnaire. We're looking at cognitive function by doing a mocker and by doing a trail making test. And those are really the other things. And then we're looking at their lipid profile and liver function tests also at those endpoints. But that's really primarily a safety point. We're not expecting to see dramatic improvements in those things. We're just demonstrating, hopefully, that there isn't an issue with increased metabolism of MTTs through the liver and so on, which is theorized but hasn't been seen.
Cheers, yeah.
So I was interested also in your description of the educational pathways having a crescendo effect.
Yes.
That was a lovely term. Do you want to expand on what you were meaning by that?
So I think it's really a network type of development, and the development in the entire area, the entire ecosystem, the actual town and region, whereby when you have more people of an academic nature who are doing more teaching, that encourages more medical students to come. Maybe they bring their partners, maybe doctors who are interested in teaching and research stay for a while. You have other types of health professionals that now have opportunities to work in the region, perhaps relating to the research, perhaps relating to something else. And so having more people doing this type of work and not it being restricted solely to metro regions allows development of the health network in general. You might have more audits, more quality improvement. That would improve the general nature of the standard of practice within the region. That might increase satisfaction. So all of these small things, these marginal benefits, these intangibles, and you get an aggregation of marginal gains, which I think was a famous cycling team quote. And so that overall, I think, would be a great benefit to the health network. But it's early days, and you have to have the faith to see it, as it were.
Fantastic. Thank you so much for that. a good time of the year to be thinking about the faith to see things as we come up to Christmas, and really appreciate you sharing what you've been doing as part of your training to become a rural journalist. Nice to know that surgery is a lower cognitive load than the rest of your week. I'm sure there'll be some people who will pick up on that quite quickly. But lovely to hear, and it's great to have so many people participating today in this grand round and looking at this in the future. It's an opportunity for us, as you say, to build capacity, to build expectation, and for our community to build hope that we will have a health service that provides the highest possible care close to home. So thank you all, and I look forward to catching up with you again next year when we resume the grand rounds for the Riverland Academy of Clinical Excellence. Nundi Andu, and we'll see you again.
Thanks, everyone. Cheers, Paul.